Welcome to our Cardio Winter Webinar, Think Well, Live Well, Brain Health Through a Holistic Lens. I'm Dr. Sherry Bolin, Co-Principal Investigator of the Ohio Cardiovascular and Diabetes Health Collaborative, also known as Cardio. Founded in 2017, Cardio's mission is to improve cardiovascular and diabetes health outcomes and eliminate disparities in Ohio's Medicaid population. Cardio brings together Ohio's 7 medical schools to identify, produce, and disseminate evidence-based best practices to primary care teams. And to learn more about our collaborative and access our online repository of best practices, please visit our website at cardio.org and download our web app. Wanted to spend a moment just thanking and acknowledging our sponsor, the Ohio Department of Medicaid, and our administrative partner, the Ohio Colleges of Medicine Government Resource Center, and also recognize our partnership with the 7 medical schools who really contribute to making cardio a collaborative and a success. Just some brief logistics, just to try and put your first and last name on Zoom so we can see that for attendance purposes. If you're joining as a group, please use the chat feature to record names and emails of all attendees. We do want your questions, so please submit questions for our discussion using the Q&A feature to submit questions at any point. We will answer those during the Q&A portion of the webinar. And then, as always, we have a post-webinar evaluation survey to really learn about what you liked and what you didn't like so we can improve these as we go. Next slide. None of the planning committee or speakers had any relevant conflicts of interest. Next slide. And then if you are interested in CME, when you registered, you could click that you are interested and you'll get a Cloud CME email where you can complete the CME evaluation. If you haven't registered, please go to the QR code here and you can register and state that you're interested in claiming CME and we'll make sure to get that to you. Next slide. So with that, I will jump into introducing Dr. Amy Zack, who will be our moderator today, as well as introduce our main speaker. So Dr. Zack is a family medicine physician, vice chair of education at Cleveland Clinic, and faculty at Case Western Reserve University School of Medicine. She serves as the head of education and dissemination for Cardio, and we're delighted to have her helping us today. So thank you.
Thanks, Sherry, and I want to welcome everybody who's joining us today. It's my pleasure to introduce our speaker. Dr. Robert Saper is the Enterprise Chair of the Cleveland Clinic, Department of Wellness and Preventive Medicine, the holder of the Nancy J. and Michael F. Roizen Chair of Wellness, and a professor of family medicine at Cleveland Clinic Lerner College of Medicine at Case Western Reserve University. Under Dr. Saper's leadership, the Department of Wellness and Preventive Medicine is partnering across the entire Cleveland Clinic enterprise to promote the wellness of patients, caregivers, the community, and the organization. Dr. Saper defines wellness as the active pursuit of optimal physical, emotional, social, and spiritual health. With over 90 providers, researchers, and administrators, the department completes thousands of team visits annually, given by physicians, nutritionists, acupuncturists, chiropractors, osteopaths, massage therapists, among many others. Dr. Saper graduated from Harvard Medical School in 1983, completing a family medicine residency and chief residency at the University of California, San Francisco, and practiced for 8 years in the San Francisco area. He then completed a 3-year fellowship and MPH in Integrative Medicine and Research at Harvard Schools of Medicine and Public Health. In 2004, Dr. Saper joined the faculty of Boston University School of Medicine, founding the program for Integrative Medicine and Health Disparities with a mission to make evidence-based integrative medicine available to all people. His career focus is the safety, effectiveness, and implementation of lifestyle changes and non-pharmacologic therapies for the prevention and treatment of common conditions. Dr. Saper has published over 85 papers in peer-reviewed journals, including very influential studies on the use of yoga for chronic back pain. He has presented over 200 lectures nationally and internationally, mentored countless trainees, and received over 30 funded grant awards. He's also a trained yoga instructor and meditation provider for over 35 years. So we are very privileged and proud to have Dr. Saper with us to speak on the topic of Think Well, Live Well, Brain Health through a Holistic Lens. Welcome, Dr. Saper.
Thank you so much, Dr. Zack, and good afternoon, everyone. It's a real honor and privilege to be able to speak with you today, and thank you so much for attending. These are the learning objectives from my talk today. One, to understand the impact of lifestyle and behaviors on cognitive wellness, to identify modifiable risk factors for decline in cognitive function, and perhaps most importantly for our day-to-day work, how to counsel on key lifestyle interventions for the prevention of cognitive decline and protection of brain health. I want to acknowledge a close colleague of mine at Cleveland Clinic, Dr. Sandra Darling. She is the director of the Women's Alzheimer Movement Prevention and Research Center at Cleveland Clinic. She has expertise and experience in just this topic and has been very formative for my own information and development of this presentation. So I want to thank Dr. Darling. So as it was mentioned by Dr. Zack, what is wellness? And for this, we take a holistic lens and apply George Engel's initial biopsychosocial model developed in the 60s and 70s and expand it to the biopsychosocial spiritual model. And as we look at a human being, I suggest that these four domains that you see here are the major domains of the human condition. As clinicians, many patients come to us with physical or bodily complaints, and that's why that domain is in the center. But we know that physical illness and disease can be contributed to by other elements in the mind, social, and spiritual context, and conversely, can impact the wellness of those domains. So by mind, I'm speaking about mental health, and relevant for this talk, cognitive health, but also emotional well-being and emotional resilience. In the social domain, of course, this includes social determinants of health, but also relationships, social connections, a sense of belonging. By spiritual, certainly that can include religious observance and practices, but moreover, it also encompasses what we as human beings have as a sense of meaning and purpose for us in our lives. What gets us up every morning, and at some level, some kind of faith that things will be okay. So many of you have seen versions of this diagram here, and I find it incredibly helpful, but also very humbling, because this is work done by a group of many investigators and developed a consensus on what are the main contributors to health and wellness outcomes across the board. And what you see here, we spend so much time in our education and our work providing medical care, and it only accounts for 11% of the variance in outcomes. Now, that is not to negate the incredibly important work we are all doing on a day-to-day basis, and I'm grateful to all of you for that work. But I want to bring your attention here to behaviors. So this is what we eat, how active we are, the way we sleep, the way we manage stress, different substances we use, the degree of interpersonal violence, whether it be verbal, psychological, or physical. All of these factors actually account for a little more than a third of outcomes. Environmental exposures are important, and I think we're really just learning more and more about this. The impact of climate, air quality, soil, water, green space. Recently, a lot of discussion on plastics and microplastics. Social, to this audience, I'm sure we're all aware of, these are all the various social determinants of health, and then, of course, genetic pieces. And so what I'm going to be focusing on mostly is what is in this behavioral and social realm here that we can potentially employ to make a difference for cognition. incredibly important to always think about equity in both health and wellness equity. And the way I define wellness equity is much like the CDC defines health equity, that everyone should have a fair and just opportunity to attain their highest level of health and wellness. And of course, what may be my highest potential level may be different than yours and different than the patient that you saw this morning. And that key distinction between equality and equity. And this is a diagram perhaps you've seen before where we have a family here, a parent, an older sibling, a younger sibling, who all get equal size stools to be able to watch the ball game. And obviously, this person, it's not adequate, and for this person, it's more than adequate. Whereas with equity, the adjustments are different so that everyone has that fair opportunity to be able to participate. And this is very relevant for the discussion that we're going to be having here, is to be able to make lifestyle changes. So much is related to social determinants of health, but I hope the suggestions I make for counseling and such can try to bridge that gap. I want to speak a moment about the human experience of dementia. Sabat in the early 90s referred to it as the loss of the self. And back to that diagram, which encompasses those 4 domains of the human experience, dementia can impact some of these or all of these. Obviously, the mind, but impacting social interaction, the ability to think larger in the spiritual domain beyond oneself. And for many people, frailty as they approach their death. This is a personal story. You're seeing my mother, Eileen Saper, here on the left. This photograph was taken in the 80s and 90s, or 90s, and very vibrant human being. Ultimately, after retirement, traveled around the world, loved to host friends for gourmet dinners and had dinner clubs before there were even, that was a commonplace thing. Very extroverted and so forth. And sadly, due to a combination of probably multi-infarct dementia and perhaps frontotemporal dementia, her decline spanned all of those 4 domains. And this is in part hinted at the picture of her close to the end of her life on the right. And she was truly a shell of her former self. And so I share this to remember, one, the human experience that your patients are going through, but also many of you will know or even care for the family members of your patients with memory loss, and their needs, psychosocial needs, medical needs, are very strong, and they start as the patient is declining with memory loss and continues past their death. So dementia, of course, is a category of multiple phenotypes. We're most familiar perhaps with Alzheimer's, which is about 2/3 of all dementias. And it's often referred to as Alzheimer's disease and related dementias, or ADRD. You'll sometimes see that acronym. However, many other types of vascular dementia coming from small lacunae or microvascular, ischemia, Lewy body dementia, frontotemporal, normal pressure hydrocephalus, and many others. And it's beyond the scope of this talk, or I think even sometimes beyond the scope of many primary care docs, to be able to understand in detail the various differences here. But I do want to underscore the importance of appropriate referral and understanding the diagnosis. So for example, with NPH or normal pressure hydrocephalus, for a subset of those patients that can be determined, ventriculoperitoneal shunting can improve physical and cognitive functioning. Certainly with vascular dementia, the prevention of further insults to the brain can be very helpful. How do we assess cognitive function in the office? I've listed here 4 common assessment tools that you may be familiar with one or more of them. Just going across the top, C3 stands for the Cleveland Clinic Cognitive Battery. MoCA or Montreal Cognitive Assessment, mini mental status exam. I remember learning this in medical school over 30 years ago. And then the mini cog, which is often employed for brief assessment, like in the context of an annual wellness visit. And they all differ quite a bit in their formats, primary purpose, strengths and weaknesses, and how long they take to process. I'll just highlight a few key points. The C3 is nice in that it's able to be digitally entered with an iPad from the patient, and then uploaded into your electronic medical record. It can sensitively track cognition over time and is particularly sensitive to early cognitive change. But as you can see here, 12 to 15 minutes it takes. The MoCA can be paper or digital, particularly helpful, and it was designed initially for mild cognitive impairment, and we'll talk in a moment about the spectrum of cognition change. Very sensitive to early cognitive change, covers multiple domains, takes a little bit less time, around 10 minutes. The MMSE, it's moderate to low sensitivity to early cognitive change, so really much more helpful to, say, confirm that the patient in front of you may have moderate or severe dementia. And then lastly, the mini-COC involves a 3-word recall after a minute, drawing a clock. It's incredibly brief, low sensitivity to early cognitive change, but takes a very small amount of time, so it's a good screening time. Personally, I use the MoCA most because of this sensitivity to that early cognitive change, where some of the interventions I'm describing here can really make a difference, and you can then also consider whether appropriate referrals or workup is needed. So this is the spectrum of cognitive function. On the left here, we call it so-called normal cognition, and on the far right, severe Alzheimer's disease. And then in between, we have subjective cognitive impairment. Perhaps many of us on this call, including myself, can relate to what this means. It's, where did I leave my keys? Where's my phone? I can't remember, I recognize that person, I can't remember the name. But they really have, pretty close to normal cognition and not necessarily a great risk for greater memory loss. This is the group here that we're really going to be focusing on mostly for this talk. And that's mild cognitive impairment, which it's a gray zone between here and mild Alzheimer's disease, and then moderate and severe. And what I've given you here is rough guidelines using the 3 different instruments, MoCA, MMSE, and the mini-COG, of what kind of scores would correlate with different changes. So for the MoCA, 26 to 30 would be normal or subjective cognitive impairment, and 18 to 25 mild MCI or mild Alzheimer's disease. So perhaps folks, 23, 24, 25 may be in this category. And as you see, it progressively gets lower. Higher scores and generally are better cognition. I want to make this point, it may go without saying, but it's very important, particularly when we're talking about wellness, non-pharmacological interventions. As you well know from your patients and your own exposure, if you go on TikTok, social media, Facebook, Google Alzheimer's disease, for example, you are going to see a plethora of recommended treatments. Much of this is untested, unregulated, unclear on safety, unclear on effectiveness. What I want to say here is that Alzheimer's disease, that right side of that spectrum, there's no evidence at this point that that can be reversed to normal cognition. However, I think it's reasonable to say that progression on that spectrum can likely be delayed through optimizing modifiable risk factors, behavioral and lifestyle changes, and future medical therapies that are currently being tested or in the pipeline, or things that we're not even aware of for the future. So, what are the modifiable risk factors of dementia that we encounter or can be aware of in day-to-day primary care practice? In early periods of time, less than 30 years, the degree of education that someone has is a modifiable risk factor for later life memory loss. And obviously, this is of great importance to us, the pediatricians on the call, the family docs, of how to help our younger patients improve their education, improve their educational attainment. The bulk of risk factors happen in midlife, and these risk factors are really the very focus of the statewide Cardio webinar and consortium, and specifically pointing to cardiovascular risk factors, high LDL cholesterol, hypertension, obesity, and diabetes, and smoking. Also includes, though, hearing loss, excess alcohol intake, a history of TBI or traumatic brain injury, physical inactivity, and we'll get to this later, and depression. And in late life, social isolation, which we'll be speaking to, a lot of amazing work on air pollution, which of course we have less impact on with our patient in front of us, and vision loss. I'm going to pivot now and talk about lifestyle medicine. This has grown in recent years as a specialty. There is the American College of Lifestyle Medicine, which is referenced here in the lower left. This is an organization that has grown in its educational offerings. They offer a board certification, in a sense, for lifestyle medicine. They give the clinician the tools on how to work with patients using lifestyle as a means of helping improve their health and wellness. And so these are 6 pillars, as they define them, of lifestyle medicine. And starting in the left side column, a whole food, plant predominant eating pattern. So I'm not promoting veganism or anything like that, but more plants than less. Regular physical activity, restorative sleep, and on the right side, how we manage stress, the avoidance of risky substances, and positive social connection. And so as I go forward now in my talk, we're going to take each one at a time, talk about the data that shows that there is a powerful, usually, association of these factors with either lower incident rates of dementia or improvement in cognition. The vast majority of studies I'm about to show you are all from observational cohort studies done over time, which can identify various exposures at the beginning and then look for specific outcomes at the end and compare it to appropriate case or controls. And I'll also be showing you meta-analyses, so pooled data from multiple prospective cohorts in this area, which is the highest level of evidence. Towards the end of the talk, we'll try to bring it all together, and I'll show you a little bit of data on where we try to put all these kind of interventions together into a package, per se, and see what the impact is in a RCT fashion where you can truly determine causality. So again, I'll show you observational data, does not prove causality. However, all that data is controlled for many, really all of the modifiable risk factors that we're aware of, and it does not, however, prove causation. So let's start with nutrition. Mediterranean diet, DASH diet, and something called the MIND diet. So studies of the Mediterranean diet, when individuals highly adhere to that diet, a 54% lower risk of Alzheimer's disease. Individuals who follow the DASH diet, which is dietary approaches to stop hypertension, initially developed to treat hypertension, a 39% lower risk of Alzheimer's. And in this diet, which is a fusion, in a sense, of Mediterranean DASH aspects, for neurodegenerative delay, the MIND diet, high adherence has shown 53% lower risk of Alzheimer's disease. So what are these diets? And this is a nice comparison here on the top row, DASH, Mediterranean, and MIND, and then here different features of the diet. I'm going to focus in on fat pattern and sodium because I think those are some of the areas where there's the biggest difference. DASH, low total fat, low saturated fat. Mediterranean really pushes a movement away from saturated fats to so-called, and certainly trans fats, and what are so-called healthy fats. That's your olive oil, different plant-based oils like an avocado, and the MIND diet sort of really moderate in between these two with an emphasis on olive oil. Certainly the DASH diet created for hypertension and strict limits around salt intake, whereas there's no formal limits for Mediterranean and MIND diet. Really across the board, red meat is either limited or strongly limited. And this is a pictorial representation. I find this helpful with patients on what a DASH diet, would look like on the plate. Half of the plate non-starchy vegetables and fruit, a quarter of the plate whole grains or starchy vegetables. I certainly personally recommend more of the whole grain, and then a quarter being lean protein, piece of salmon, other kinds of fish, as well as poultry. And Mediterranean diet, this is, and there's links here, and you could print these out. These are foods that you want to try to eat at every meal: fruits, veggies, whole grains. These at least 3 servings a week. And note the focus on nuts and legumes, something that we leave out a lot. Helpful plant oils in the nuts, legumes, great source of fiber. 1 serving a day, the poultry, low-fat eggs, and limit to 1 serving per week. Red meats and sweets. And this is sort of different types of foods in those different categories. And I want to spend a moment on UPF, or ultra-processed foods, very much in the news of recent. And these are important. They've been independently associated with all-cause dementia and vascular dementia specifically, not Alzheimer's alone. A prospective observational study of over 72,000 people, median follow-up of 10 years. If you take the first quartile of UPF consumption in their diet, so that's 8.6% of their diet, versus the fourth quartile, where almost 28% of their diet was ultra-processed foods, we'll take a look at the hazard or odds ratios between this highest versus lowest quartile. All-cause dementia, 1.51. That means a 51% increase risk. Alzheimer's disease, yes, greater than 1, but as you see here, borderline statistical significance, the confidence interval crosses 1, and vascular dementia, 2.19, statistically significant. So how do we counsel patients? Hey, behavioral change is really hard. I always say whoever can, invent the solution to behavioral change will win a Nobel Prize. But as primary care physicians, always plant the seed. Be patient with our patients. Use motivational interviewing to assess their likelihood to change, confidence and ability to change, as well as having the knowledge for that change, and then adjust your counseling appropriately. We should not underestimate the power of our therapeutic relationships as clinicians with our patients to create the trust and willingness to follow our recommendations. A patient who may had said no to a Mediterranean diet, for example, if raised by a family member or stuff, if you say that to them, they may say, I'll go for that, and I'll go for it because you are telling me to. An essential aspect of patient-centered care is what matters to the patient, and try to link what matters to that behavioral change. So if, the 65-year-old says, I really want to be there for my grandkids as they grow up, I want to be at their graduation, and that matters to them, well, behavioral changes now in the 60s can make a potentially big difference in their capacity to not only be there, but also to be there in a highly functional way. Food label literacy. Many people do not understand how to read food labels. Bring it up on a Google screen on the computer and just go through it with them. And I'm sure many of you know this, but it's helpful to counsel patients. The periphery of the supermarket is less processed food than the central area. Here are some resources for nutrition. You can refer to your local nutritionist or cooking classes. We at Cleveland Clinic have in-person or virtual nutritionist, and also culinary medicine. Culinary medicine is teaching people actually how to do the cooking. You can embed smart phrases into your EMR. These are handouts from Cleveland Clinic, National Lipid Association for Mediterranean Diet, and a group of different recipes, including from Ohio SNAP-Ed, and tools here on the Mind Diet. Switching to physical activity. This is a forest plot. These are all prospective cohort studies that look at the relationship with appropriate controlling for confounding between cognition and physical activity. The mean follow-up for these studies is almost 13 years. Mean baseline age is 67. The risk of all-cause dementia when you meta-analyze this is 0.80, therefore a 20% decrease. For Alzheimer's, 14% decrease. For vascular dementia, an 11-point decrease. And you see that here outlined in red by this overall pooled effect. Now, what we don't talk about as much as the inverse of physical activity, which is very common and can even be its own independent risk factor. So physical inactivity or sedentary behavior is defined as any activity while awake with energy expenditures less than 1.5 minutes in a seated or reclined position. So this is watching TV, driving, or using electronic devices. And they've actually done meta-analyses where they look at sedentary behavior and cognition. The trick here is that there's variation in the studies on how sedentary behavior is defined. And so in these 5 studies here, really defined as television viewing, and you see a clear positive hazard ratio. Interestingly, the sedentary work we do at the computer is not associated with increased risk of cognitive problems, probably because of the intellectual stimulation. We don't really understand. And then a variety of other definitions here used. We see a positive impact on sedentary behavior on worsening cognition. I want to speak just for a moment about a different type of exercise, and that's cognitive exercise. You'll see a lot of things that people do or are recommended to stimulate the brain. And this is just a picture of one of hundreds of these. It could be Sudoku for your family, or crossword puzzles, or reading, or so forth. There was a systematic review of 11 RCTs for cognitive training in older adults who had normal or mild cognitive impairment. In healthy older adults, the training improved the domain that was being trained on. So, for example, Sudoku would improve processing of mathematical formulations, but it didn't necessarily consistently generalize to other domains like executive functioning, word retrieval, and so forth. So in MCI, the results were mixed. Overall, low or insufficient strength of evidence. So I don't think we could say with definitive confidence that these kind of brain exercises will delay progression. However, they can be fun, they can be engaging, and certainly a reasonable thing for someone to do, particularly if their days are not filled with other, activities that are meaningful or intellectually engaging. So when we talk about counseling for exercise, we all do this on a daily basis. Finding a buddy is very helpful to do it with. We know about exercise prescriptions. This is the FIT acronym. recommending a frequency of exercise, how intense the exercise should be, mild, moderate, or vigorous, the duration of time and type. And it's really okay to start small. I'll often encourage patients, who say, I don't have enough time to exercise, and I get it. It's the same for me. Do you have 5 minutes? Yes. So we start there. A question I love to ask, there's no reference for this or evidence, this is from my own clinical experience. I asked this yesterday to a patient who was sedentary and wanted to lose weight. I said, what physical activity gave you joy when you were younger? Immediately the patient lit up and said, swimming. I was on the swim team, I did all the stuff and blah, 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 blah. And there you are. And so try to help that person link back to some form of what they enjoyed in the past. Here are different examples for physical activity resources. You really need to find those in your community. YMCA, senior centers, community centers, Jewish community centers can all be helpful. These are various YouTube sites, obviously, that are free, that are popular with good ratings. At the Cleveland Clinic, we offer these free live stream classes. That's a link to register. Also, in the Cleveland area, for those of you who are here, there are free community yoga classes available that can be registered for. Moving into sleep disorders, we talk about sleep all the time, and very often we focus on this last one here, right? Obstructive sleep apnea. Let's start there. Definitely associated with onset of MCI and Alzheimer's, and treatment improves cognitive function in older adults with OSA and Alzheimer's. However, it's not just OSA. So insufficient sleep syndrome. I'll share with you a personal vignette. I never heard of that term until I went to a sleep doctor and they diagnosed me with insufficient sleep syndrome, which basically means we're not getting enough sleep. And I suspect it may be quite endemic in the population that is watching here. We're medical professionals. We have a lot to do. But it does impact memory formation with a small standardized effect size of 0.29. Irregular sleep-wake rhythms is associated with worse executive function and working memory. So the folks, I go to bed different times, sometimes 10, sometimes 1 or 2 a.m., or folks who are on, shift work and so forth. Insomnia itself is associated with greater risk of dementia, and these are really important to try to address. How to counsel. I won't read all of this, but this is basic information on sleep hygiene, and I have that as a smart phrase, and I'll copy and paste that and maybe talk through it verbally. These are a couple apps, Insight Timer, Calm, and Headspace. They're great for that wind down period right before bedtime. That can be very helpful. Let's talk about stress management. I want to make the distinction between a stressor, that's an event or action, usually external to ourselves, but could be internal, like an illness, for example, and it causes a state of stress. Sometimes these stressors are controllable, very often not controllable, and stress is the experience of or the response to that stressor, and that is what we and our patients can control. Acute stress is not always a bad thing. Chronic stress, however, is associated with multiple health conditions, including issues around cognition. And this is sort of a hypothetical diagram of acute stressors with an adaptive response where we come back to baseline. But for many of us and our patients, we have a stressor, we don't come back to baseline, then another stressor, we don't come back to baseline, and we're living in this chronic stress area. So these are different levels of evidence and studies looking at the association between stress and cognition. Won't get into the intense detail here, but these are studies that actually looked at cortisol, which is part of the HPA axis and associated with worse memory. A systematic review looking at people exposed to chronic stress and on volumetric MRI showing greater atrophy of the hippocampus, where is an area important for memory. Prospective cohort studies showing that repeated stress increased dementia risks. So stress response is mediated by the HPA and also the autonomic nervous system. Stress management techniques, whether it be deep breathing, meditation, yoga, they likely all work through the common pathways through these two systems. There are small individual RCTs that show benefit in cognition in healthy patients, SCI and MCI, and patients with dementia. Certainly safe and reasonable to recommend. Just a moment on mindfulness. That is one of the mindfulness activities, one of the stress management activities that can be done. And I like to share this cartoon with my patients. These two women are walking in nature. Nature is a wonderful stress-reducing activity. This person is in the moment. She's being mindful, but this person's mind is full. And I think what you'll find with your patients with subjective cognitive improvement, they are multitasking, they're thinking about many different things, and that can often contribute to memory challenges. Mindfulness practice has been found to enhance cognition and focus, working memory, attention, stress, depression, anxiety, and distractions, all relevant for cognition. How to counsel patients. I use the term stress a lot because patients can relate to that, particularly for SCI, educate patients on how stress and multitasking can result, as I spoke about, in common forgetfulness. I educate patients about the sympathetic nervous system, the parasympathetic nervous system, in a very straightforward way, as the flight or fight or the sort of calming arm. There are different quick things you can do in the office. This is a diagram for what's called the box breath, which you can do with a patient for 1 minute, and you can help that patient very often experience a relaxation response. These are different resources and examples for stress management activities that are online, different apps, different courses. Avoidance of risky substances, this goes without saying, but just want to share with you here a few references that describe both tobacco use and alcohol use as important risk factors, and counseling them on that when they're present. Social connectedness is defined as the experience of belonging to a social relationship or network. We have a strong human desire for connection. When this is disrupted or absent, it impairs functioning, including mental functioning. A quarter of adults more than 65 are socially isolated. There's a second but distinct construct that has some overlap, that's loneliness. Feeling isolation, feeling disconnected and not belonging, but it's subjective. So a person can experience loneliness even when there's many people around them or they have these relationships. And this is really quite prevalent. This data is from 2018 and 2020. Likely associated with cognitive decline, this is a meta-analysis showing a 12% increase in high loneliness, infrequent contact, and low group participation increases dementia risk even by as great as 50%. Social prescribing, I won't get into the very detail of it, but essentially it's us working with our patients recommending that they participate in some activity in the community, volunteerism, a class, something at a senior center, being a docent at a museum that will get them in contact with others. It's a very common approach used in the United Kingdom and Canada, and has good data to reduce loneliness and social isolation. And what we've done here is provided some statewide options, as well as options in Cleveland area, Cincinnati, and Columbus, for some potential resources for you that I strongly encourage you to curate for your local area. So briefly, these are RCTs where they took a combination of different interventions like I've shared with you: diet, exercise, cognitive training, vascular risk monitoring, against control groups. And this study was done in Europe and actually found change in cognition to be improved, 25% higher in the intervention group. This is a study by Dean Ornish, who has used lifestyle changes in cardiovascular disease and prostate cancer and he looked at the progression of MCI, early dementia. And his intervention includes whole food, plant-based diet, a few key supplements, aerobic exercise, stress management, meditation, gentle yoga, and support groups with a partner and spouse. So a very intensive lifestyle change and really impressive group differences on some of the standard dementia instruments that are used in studies. Some of the limitations, there was lack of blinding, no adjustment of the p-value for the multiple different outcomes they were doing, lack of a consort diagram in the paper. These are ongoing RCTs where we're combining these different interventions in one. So these are all ones to look forward to for potentially greater data. This is a shared medical appointment that is a resource for you here at the Cleveland Clinic, and it was developed by Dr. Darling, who I mentioned before, and it's 6 group visits every other week. And it can be virtual or in person. It's paid for by insurance. And all these topics that we've been talking about, the mind, diet, activity, and so forth, are covered. And we have some very positive outcome data on that. So to sum up, dementia has many causes. It can be devastating to the patient and family and currently cannot be cured. However, lifestyle and behavioral changes may lower dementia risk and slow the cognitive decline. This may be mediated through modifiable risk factor optimization, that list I showed you before, and or direct mechanisms of diet and so forth that we don't fully, understand at this time. And I encourage you to prescribe, much as we prescribe medications, lifestyle modification or changes to patients at risk of dementia and those with SCI or early MCI. And with that, thank you so much for your attention. I'm happy to take any questions or comments.
We do have a couple of questions. I want to remind everybody, if you do have questions, please use the question and answer function on Zoom. And a couple of things to start with. We know, as you mentioned, the impact of stress on cognitive decline, cognitive ability. What strategy do you use for folks who have a history of maybe adverse childhood events, PTSD, and how does that impact their cognitive outlook?
Thank you so much. Those patients will benefit from more intensive work with a psychotherapist who has expertise in trauma and trauma-related practices. EMDR is an evidence-based practice, mindfulness-based cognitive therapy, and others. And we can talk about that further. We do some of that work here at Cleveland Clinic, and I'm sure at many of the centers here.
Our patients are often asking about supplements. There are many advertisements, we won't use any brand names, that claim to impact cognitive function, dementia, the development of dementia. Do you have any supplements that you find that are evidence-based or that you recommend to your patients?
Short answer is no. There are reasonable, safe supplements that could be recommended for any healthy adult, 50 or 60. If you have concerns that they're not getting an adequate diet, a good multiple vitamin, omega-3, vitamin D, and so forth. But really, no supplement that we've identified that has evidence to reduce the risk of or the progression of cognitive decline.
Can you comment on whether there's a link to between the use of SSRIs or SNRIs and the development of dementia?
Thank you for that question. I don't have the expertise. I don't have an answer to that question. It's an interesting one. It has not come up for me in my research for this talk or experience, but open to anyone here on the call or others or communication afterwards about that. I think we're all familiar with this concept of pseudo-dementia, which is the patient with depression and it manifests as memory problems. And obviously that would be a circumstance where aggressive treatment with SSRI, SNRI could be helpful.
Additionally, there's a lot of sort of media discussion, of course, about medications, vaccines, and this person is asking about any evidence that actually does connect the zoster vaccine and the slowing of Alzheimer's dementia.
Yes, yeah, it does. We have evidence that Zostrix has an association when you control for confounders to a lower incidence of dementia. And I think it's a really important point. Thank you for asking that question. And I can, if you want to give your email, I mean, I can share the data or the references for that later.
What are your thoughts around shift work? Is there a connection between those who work third shift or have a change in sleeping schedule over a long period of time and cognitive health?
There are, statistical associations from multiple studies showing that. So I can't say that it's a healthy thing to do, but obviously people have to do it. So then we have to be really creative on how to counsel those patients so that we're assured that they still have a regular bedtime and a regular wake-up time. They're actually getting 7 to 8 hours of sleep. Many of my patients who are on shift work, they describe, yes, a regular rhythm, but 4 to 5 hours. Any comorbid sleep problems like sleep apnea is treated. And I will say that melatonin, although it's not an agent for insomnia, has been definitely demonstrated to be very helpful for sleep phase disorder, which comes from shift work.
We have a question about why DASH diet is sort of takes the forefront on dietary modification as opposed to the Mediterranean diet in the U.S.
Been around for the longest, I think. It's a great acronym, easy to remember. And it's a very good diet, and it's been effective for, for some patients with blood pressure. So we don't want to throw out the baby with bathwater, you know what I mean? Whatever positive movement we can have in terms of health is a good thing. I think certainly if your patient has that comorbidity of hypertension, it's very helpful. And that is also where, I'll just share my own clinical practice. That's where the food label education is so helpful. And I show the sodium line. And this is somewhat arbitrary, but I say that if you see a food which has a sodium per serving of greater than 150 milligrams, that's a high sodium food. And when people start looking at the labels, lo and behold, there's a lot of high sodium foods out there.
You mentioned lots of different interventions, different lifestyle changes that can be helpful to support cognitive health. Where do you start with a patient who has a long way to go? Sure.
So I try in my primary care practice to touch upon initial screening questions on all those different lifestyle domains. Do you feel you have any extraordinary stress in your life? How do you manage stress? Those are examples of two. Tell me what your diet is like. Tell me what a typical day is like, for your diet. Are you physically active, and how so? When do you go to bed? When do you wake up? And do you have any trouble with sleep? Do you feel like you have strong social network, friends, family, or do you feel more kind of lonely? Obviously, if someone is sort of positive on that, then you can get a little bit more in depth. But this gives you a nice sort of sense of where the strengths and where the challenges are. And I go for those opportunities where there are challenges. And when there's openness from the patient, obviously.
Thank you. And finally, what specific recommendations do you make in helping to encourage folks, but also give them guidelines on maybe how much exercise, steps per day, that kind of thing to get folks moving?
Absolutely. So you want to know what their baseline functioning is. If they are sedentary, watching TV, really haven't done anything, then what I'll have them do is use a simple watch, or most people have a phone, measure their steps using a health app, and see what their average steps are. Per day for a week. Send me a MyChart message. It may be 1,500. I saw a patient yesterday. They're working totally from home now, and they see that. So we start with that 1,500, and then we set a 5% increase in goal, and then try to increase that goal, every week. We don't just have folks start at 7,000, but if you can get folks to 7,000 or greater, 10,000 even better, that is an awesome goal.
Wonderful. Thank you so much, Dr. Saper, and thank you for taking the time to answer questions. We appreciate you being here today. And thanks to all of our attendees. I'm going to pass along to Sherry Bolin to wrap up.
Thank you, Dr. Zack and Dr. Saper. Wonderful webinar thus far. I'm going to go through some brief wrap up. Just again, a reminder, if you want CME, you need to have registered and selected that you're interested in CME. And if you haven't done that, this is the QR code and there's a URL in the chat. Next slide. We want to hear from you. We're going to ask you to evaluate our webinar. So you'll see that coming up as this ends, and you'll see the survey link. We'd love your feedback so we can make these as wonderful as possible for all of you. Next slide. Just wanted to promote our webinar. We've already figured it out for February, is From Prescription to Practice, Tackling Adherence Challenges in Clinical Care. Always a challenging area to address and around engagement and care, so looking forward to that. Next slide. And again, just thank you all for attending this wonderful winter webinar, and for our speaker and moderator. If you're interested in learning more about cardio, feel free to go to our website, as well as follow us on social media. Thank you all, and have a wonderful rest of your day.